David C. Luce, M.D., is a graduate of Brown University and Harvard Medical School. Dr. Luce is a member of the Board of Directors of the American Society of Addiction Medicine, the National Council on Alcoholism and Drug Dependence, the Association for Medical Education and Research in Substance Abuse, and the Drug Policy Alliance. He's a fellow of the American College of Physicians and chair of the Professional Advisory Committee at the Caron Foundation, and the founding editor of Data, the Brown University Digest of Addiction Theory and Application. Dr. Luce received a Rockefeller Foundation Residency Fellowship at the Bellagio Center in Italy, and is currently Project Director of Physician Leadership on National Drug Policy, a national policy initiative advocating greater use of medicine and public health in approaching drug problems. In December 1997, David C. Luce, M.D., received the American Medical Association's Education and Research Foundation Award in recognition of outstanding contributions and leadership in championing the inclusion of alcohol and other drug problems into the mainstream of medical practice and medical education.
A lot of reasons why this is a chronic disease. The situation that surrounds it sometimes helps, the availability of drugs, or the social situation that may promote and not prevent. Once the brain changes in a way and adapts to these drugs, you're in a bad cycle. That's the trouble. And I think you have to treat people and try to make them better, whether they go totally abstinent right away or not. And the other side of that coin is confusing abstinence and treatment. To think that once you get somebody cleaned up from what they were doing, they don't need some specialized kind of support in the future. Whether it be 12-step that helps them or any other, including medication-assisted treatment. There's a bias against using medication in addictions.
Bill W. did.
I mean, methadone is a good example. People were against methadone because they thought it wouldn't help heroin addicts. And it does. It's the most effective treatment by the numbers that help people over the long term. So detoxification is not cure, and sometimes people need assistance while they're getting better, not after they got better. And they need help afterward to adjust to some of the situations that they screwed up during their active addiction. It's a fairly complicated disease. It needs social support, it needs housing, it needs family education, it needs prevention. It needs an understanding of community, and community needs an understanding of addiction. And all of this has to be taught eventually in medical education. Addiction has to be one of the central elements in medical education. And I think the epidemic we have now with opioids has changed our whole attitude toward medical education in medical schools. And among the judiciary, it's very interesting. Recently, Brown's been approached to revise something that we did when I was more active as a professor there, which is a bench book for judges to teach judges, help teach judges about addiction. There's basic education. I went through a basic education for myself over time because of the choice of a term paper that got published in the New England Journal. I think a lot of people have to go through that basic education to understand. Police are going through it now because of the overdose and the use of Narcan, and it's beginning to change their attitudes toward what can be done. That incarceration is definitely not the answer to this problem, and more incarceration is not the answer to this problem. That's for sure. Not just a medical statement, as a social statement.
Walk us through the different ways in which you became the go-to guy.
Well, I think part of it was I was very active in the city of Boston. We had the Coordinated Council on Drug Abuse. We had all kinds of programs that throughout the city, prevention programs, marches against addiction, and all kinds of support for the development of more medical care in relationship to addiction. Tip O'Neill was there. Norman Zinberg, who was a psychiatrist with whom I worked from day one, was friendly with Senator Moynihan. And these characters were constantly trying to change the policy, and they needed help. So I ended up testifying before Congress, I guess starting in about 1980 or something like that, maybe 82, maybe earlier, maybe in the 70s. Started with amphetamine regulation. And once I got started and became known as a physician that understood something about the policy and understood something about the political and legal process, I kept getting called on for education. And so that was part of it. It was part of my self-teaching. You sort of learn and you see how the system works. There was a congressman from New York, Jim Scheuer, who invited me into his office, and I would sit there for a couple of days with him. He was very generous. We were social friends, and he was damn well set to change the laws to make it better for people that had the disease and not punish them. So I was on his side, he was on my side. I spent a couple of days in his office hearing people come in and trying to get new legislation. That was an enormously important experience for me. And I guess just these continuous repetitive experiences with the legislative process, and occasionally there were boards appointed. The other part of it is boards of directors of the medical side of it, which had to decide what to do with the policy. I became active and eventually the president of the National Council on Alcoholism and Other Drug Dependence. And we had to decide what to do. The issue there was really interesting for me as a physician. Drug addiction was dominating everything, partly because of the criminal justice side, and alcoholism was the biggest problem. And it was an education for me to see that. In the National Council, the emphasis was often on alcoholism, and the various kinds of local groups focused in that direction. And I became aware that the problems people talked about all the time were sometimes the heroin addiction or the drug addiction piece. Alcohol not only being a drug, but being the drug that was most associated with crime, most associated with accidents, most associated with destroyed families, largely because of the large number of alcoholics, and even premature death, sometimes compared with the others. So this was part of my educational process. To be on the board of a social group or a medical active group, or even a medical group, American Society of Addiction Medicine, or a subset of that, the education group, AMERSA, the Society of Medical Education and Research in Substance Abuse, which gathered together the professors of medicine, largely, and psychiatry in the country who were teaching this, and compared notes with what we were teaching, why we were teaching it, put us in contact with medical students nationwide. I'm still very active in those groups. We've set up a separate group that goes to sets up regional groups that connects with the medical establishment, sort of like this EMERSA group. And my office at Brown was, for a while, the office of the medical education group. We made a curriculum in 1982 that was used briefly by about 85% of the medical schools. It had a piece in it for OBGYN problems. And the March of Dimes bought that and distributed it to all the OBGYN residents in the country. So I got very, I got very interested in what we could do for medical education, what we could do to bring teaching about alcohol and drug problems into primary care, into the training of every medical student, to push back on what my initial experience was. A stigmatized disease that people didn't want to do with a criminal justice emphasis, with signs in every emergency ward in Massachusetts that frightened people that needed help away. That's got to be changed.
Plus the shame and the guilt and all of those stigmas.
Prevents people getting care and convinces them it's all their fault. No matter what science tells them, helps convince them. It's a very vicious circle. Helps keep it a chronic disease.
Steroids were a bigger problem than the drugs and the alcohol, or they just didn't address the drugs and alcohol?
Steroids were an interesting problem in terms of the pressure that athletes are under to perform at all levels. And anything that could improve performance became equal to something like an addictive. You know, would someone ruin their career noticeably in order to win? The answer is yes. It didn't make sense, but it made sense to them. I had friends that specialized in this, and it was interesting what their experiences were in the sports world. They could see the differences in the bodies of people that were taking these drugs, and it became self-evident to everybody. The fact that people got caught was no surprise to anybody. At a certain level, it didn't make sense. It was similar to me to what I experienced with addicts, who at some level knowingly were destroying themselves and couldn't help it. It requires an explanation, and science has been helpful. It definitely requires an explanation. How could this happen? I mean, you can understand how a spree decision by an adolescent would be understandable. A taking of a risk. Let's see what it's like to get high. That part's really understandable. But that something would happen between that and the kind of destructive behavior we're talking about, that's the part science really has to understand. We really have to understand it so we can develop better treatments.
What can we do from this point on to help medicine, law enforcement, and humanity itself?
I think we've gotten to the point that we do understand it better. The public understands the disease aspect of it, which makes it easier for them to understand it's not all your fault and lessen the stigma. It does pave the way for the development of more research and more treatment. And more research and more treatment is part of the answer, that's for sure. That's become very self-evident in what's happened recently with the opioid epidemic. You have something like 80,000 people dying of overdose in a year. You damn well have to develop a good response to that, an emergency response that makes sense, and a treatment response that makes sense. That takes resources, not just punishment. That takes employing public health methodology to understand it and to do something about it. That's part of the deal. And I think we're moving in that direction. We're moving quicker because of tragedy to people. And we're moving quicker in medical education because we're in an epidemic. Large numbers. You can't avoid it. Students have to know how to do what we know now know how to use Narcan for overdose. Oh, there's addiction medicine specialty now, and that's developed relatively recently. The American Society of Addiction Medicine is one of the specialized groups. I was a member of their board for a while, and they've spun off and helped develop the American Board of Addiction Medicine, that is like a medical board for specialists. It's a multidisciplinary specialty. It's not all psychiatrists. It's many psychiatrists that are involved, partly because psychiatrists have their own subspecialty within psychiatry, which specializes about addiction. I think specialty, if you talk about United States medicine, you can count on a specialty developing. We have more specialties for everything, and not enough going on in primary care. The challenge is even more to develop the primary care piece, what every doctor knows, but the specialty has been relatively recently developed, and it's a very, very important benchmark for the future, because the specialty will tend to encourage specialized research as well. That's done better at NIH. We have much better institutes for specialized research. I had some experience in that as well, being on one of the boards of the National Institute on Drug Abuse, and saw how it worked from the inside, how the grants got approved, how hard it was sometimes to get the kind of funding from Congress that we needed to do the kind of research we needed. There are a lot of educational efforts that didn't exist before. Like I said, there's national boards. With those go national conferences. Some of those conferences are popular in terms of learning about this, hearing from people that have become specialists. I think that part is better. I think the research part is clearly better. Treatment part is slow to improve. There's a lot of issues there. There are some struggles among the constituencies in the field as well, which requires a lot of combined experience and education. So I think we have to get very innovative when we talk about the word education. I can talk at some depth about medical education, but the public education part is equally important. That's the part that if you do a Gallup poll, you find that people believe it's a disease now, and people believe it not only needs treatment, but the treatment works. That's changed from the past. Some of those beliefs allow for other parts of the problems to be addressed and eventually be solved. It becomes clear where the vacuum is. That's what medical education did for me. Not that I was taught what I think I would teach medical students now, but that I saw the vacuum because it was so obvious. I saw what was missing. It was so common, and it wasn't being addressed. I think at some level, that's been occurring all the way along. The more we know about it and how common it is, the more the pressure should be and may not be for more research and developing and evaluating better treatment. I'm hopeful at the direction. The research direction is really good. The education direction is clearly positive compared to what it was. The stigma is less. The public understanding is more. I think there's a lot to be encouraged about. There's a whole other dimension, this role of different parts of the society. Churches, religion, and how they approach a problem like this. I think educating the public has profound effects on the different social structures in society. I gave an example of how police are reaching out, fire departments, trying to refer people to treatment, and getting frustrated that there isn't more and better treatment available. Well, I think this is happening with every unit of society. I use the churches as an example, because that may be the haven that made a difference. certainly gave us a free clinic at one point. And it gives a lot of people a moral foundation and hope as well. But for that to happen, if it's only judgmental and makes people more guilty, it'll do the opposite. That's very tricky. I was on a panel of the Institute of Medicine that evaluated the military approach to this. And that's exceedingly interesting in terms of the training people get and what's expected and what people get away with and how in the military in terms of taking risks and making it risky for others. How they understand what this is and what to do about it. How many really good trained people they have. Rick Orstrom's a dynamo, and the idea that you would have a conference that brings all the components of the field together to safely discuss their commonality as well as their differences is an interesting idea. To be open-minded in the process. I met Rick on the board of directors of the National Council on Alcoholism and Drug Dependence, and we became friends and are now. And he's had various projects. While he was on that board, he had a project that was research-like, but not really a research project. He wanted to develop a good enough understanding of outcomes that instead of paying for units of care, we would pay for the outcomes of care. That people would follow patients in the medical side in such a routine way that they knew what happened to them and had a good idea of how. He was searching, I think, in a common sense way to change the way we paid for care, because as we found more effective care, instead of relying on the heavy-duty research that was my job at Brown University. I was head of a research center at Brown. The grants were very complicated. Sometimes took a while to get funded. Sometimes we had to go through more than one cycle to get approved. And then the grants, once they got done, even if they were successful in showing something meritorious, there was a publication process, reviewing of papers, and all the rest. So it could take a year or two to find something out by one of the more elaborate controlled studies. Rick was trying to build it into the system by building it into the insurance reimbursement system. So everybody would be expected to do it. One of the things I did in the private sector was to be on an advisory board for the Caron Foundation, which I think at the moment, Caron is in Pennsylvania, and I've been chairman of the medical advisory board for a while. I've learned a lot from that because Caron has attempted to build into its system, once somebody leaves, not only events for alumni, but follow-up research events built in. University of Pennsylvania faculty working with them to routinely follow up and see how people are doing. And insurance benefits can be tied to that. That's part of my C4 education, is watching that whole effort develop, be resisted, and succeed in some specialized spots. A lot of ways to change the system once you understand it. It's been dynamic for me. It's been a learning experience. And I've learned from patients and colleagues more than I've learned from any course or books. And the fact that it happened almost by an accident, a term paper choice, and sort of filling the vacuum of what I observed, it's hard for me to look back and say, I think any one person that sort of gets into this field makes an important contribution for the people that you care for and their families. That's what counts. I have no concept of how I would affect a field or anything like that. I did what I could. I made up for some of the problems that, some of the activities that were missing. And I learned a lot in the process. And I have no complaints. It's not what I ever dreamed of doing, or nobody thought I would. And when I got started, when the stigma was still strong, I think a lot of people thought I may have been a promising physician that went astray. And I had a number of people come up to me, sort of baffled. You know, why are you doing this? No, that's not happening anymore. That would be my example. Nobody comes up to me now and said, why did you waste your career on this? That's my answer. That's good enough for me.